Good evening, everybody. Welcome to tonight's immunisation update for 2024. I would like to welcome you all. My name is Kira Wright. I'm the immunisation team leader here at Central and Eastern Sydney PHN, and I'm joined tonight by my colleague Mimi Campbell. She's the immunisation program officer here. I'd like to start by acknowledging the traditional custodians of the sovereign people of the land across which we work tonight. For me, that's the Dharawal people of the Eora Nation. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal colleagues joining us tonight. My slides weren't going, there they go. A bit of housekeeping. Please note that this webinar will be recorded and will be available on the CESPHN YouTube channel within the next couple of days. At the end of this webinar, the evaluation survey will pop up onto your screens. We appreciate your feedback as this allows us to complete, and it also allows us to complete your certificates of attendance. There is a Q&A box, so if you'd like to use that, and we encourage you to do so, please click the Q&A button and then you can enter in your questions. We'll try and facilitate those at the end of each presenter, but also we'll have a Q&A section at the end. Tonight's webinar is RACGP accredited for 1.5 hours, and there's also a reviewing performance of 1 hour, so that activity will be emailed to you post the event. We have some upcoming events for you review, and the upcoming practice nurse events as well. We currently have a practice nurse workforce strategy in draft, and we're seeking expressions of interest for small focus group sessions. So those are the dates there. If you'd like to attend, please email practicesupport@cesphn.com.au email. We have a new mental health service directory, and that's available on our website. You can filter to what the services that you require, and there's the email there as well if you require more information. Our Vax at Home service is still running, so if you have housebound patients 16 years and older, a GP referral is required, and there's further information at that website. And as well, you'll receive all these slides post the webinar, so you can go back and receive whatever websites you need. Our immunisation team is here to help: cold chain management, NIP assistance, overdue reports, COVID-19 vaccine transfers, anything that you need support with regards to immunisation, please email us. That's our email there, immunisation@cesphn.com.au. And also our website is kind of a one-stop shop for everything you need to know. So if you don't know or you need to seek further information on something, it'll probably be on our website. But always reach out if you need. I'd like to now introduce our first speaker for this evening, Dr Archana Koirala, who'll be presenting on the latest updates in immunisation. Archana is a paediatric infectious disease specialist and general paediatrician who joined NCIRS in 2018. She's part of the New South Wales Immunisation Specialist Service and reviews children who have experienced an adverse event following immunisation. She has a special interest in using genomics to understand vaccine preventable diseases and management. So welcome, Archana. Thank you very much.
Thanks heaps, Kira. I'm going to share my screen and hope it goes. So I can continue. And then that is, I think I'll just try to do that. All right. Which screen? Can you see my screen?
Yeah.
Clearly? Okay.
Yeah.
Main presentation mode. Okay. All right. Well, welcome everyone. I think I saw around 136 of you, and so thank you for inviting me to present on immunisation and an update. And I too, sometimes my screen goes a bit funky, so I have to go back and forth. I too would like to acknowledge the traditional custodians of the land in which I reside and work, and that's the Darug people, and pay respects to elders past, present, and emerging, and also extend that respect to any Aboriginal or Torres Strait Islander people attending the webinar today. All right, so, okay. So today it's a tour de force because I've been asked to talk about so many different VPDs, including the respiratory viruses and everything kind of else that's kind of new in the vaccine sphere. And I'm really excited to talk to you because we've got so many kind of new things that have come last year that we're going to revise on, and so many new things this year. But it also means that there's just a lot to cover, and I'll try my best, but I really need you to help me because it can get quite boring, I think, at 7 p.m. at night just listening to me speak. So I've got a scenario-based teaching with lots of multiple choice questions that can you please participate? I can't see who says what, and it will just make me feel a little bit better on this side of kind of the video. All right, and please do input into the chat. I think my other co-hosts can kind of read the chat and feedback. I can't seem to see it myself. Okay. All right, so before we embark on vaccination, I just want you to meet the Sullivan family. So you'll learn a little bit more about the Sullivan family, but it consists of Mark, who's the dad, Nushin is the mum, and she's also pregnant. And there's Ethan and Maya and Arash and Elnaz, and they're the 4 kids. And, you know, as I said, one is on the way. And Nushin's parents, so Maria and Ron. Oh, Ron's name got removed, but his name is Ron and he's 75. All right. So really, you know, I'm going to first of all talk about the respiratory virus, so COVID, flu, but that other niggly one that just came in and went, which is RSV. So Mark has the first question and he says, I'm interested to know which virus between the flu, SARS-CoV-2 and RSV is currently circulating most in New South Wales. So please pick one and I'll give you a good 30 seconds. Yay, everyone's seems to be working and everyone's onto it. All right, 30 seconds is up. So any last minute ones you can put in as well. So it looks like RSV has 1, and then SARS-CoV-2, and then the flu. All right. Good. Okay, well, let's see. Well, it's come up, and I think you guys, most of you are right, because you can see that COVID's still, you know, it's still ticking along. I've got quite a few colleagues who are at home with COVID, the RSV has now kind of gone on an uptick, so it's on the rise. And the flu, fortunately, it's still kind of at bay, which is reassuring because, you know, we haven't had the flu vaccine distributed just yet. All right. Okay, so I'm going to talk to you a little bit about the flu, and I'll try to fly through this so that we can go through more scenarios. Oh, my things go all a bit funny, sorry. Okay, so the first figure is notification, and the second figure is hospitalization. The red is 2003, and just looking at last year, we can see that it was probably a bit of a barn door year, right? So it wasn't as high as 2022 in terms of notification. It wasn't high as 2017 in terms of hospitalization, but it was still, you know, one of the usual flu years we see, very different to the years during the pandemic when we saw, you know, single-digit flu notifications. So that was last year. And then what about that was nationally, and this is in New South Wales. So again, New South Wales it went that peak in the middle of July, and then it's subsidized. And you know, there was equal flu A to flu B proportion. And if you look at New South Wales now, it's quite low, we're just waiting for that uptick. Okay, second question. In 2003, so out of everyone who had the flu, which age group had the highest notifications? And you can pick up to 3 if you're able to. So go ahead. in the ether? One person has voted. Okay, cool. Now we're off. This is good. It like helps me feel like I have purpose when people are contributing. So thank you. Okay, I might end poll. And so the large majority have said 0 to 4 years, the second 5 to 9, and 10 to 15, 10 to 19, similar to 20 to 19. Let's go through, and a proportion also said, in the 7 to 79-year-olds. Okay, all right. Well, let's look at the data. Whoops, let me just stop that. And these are, those fortnightly or weekly reports that come out. And you can see here that in terms of notifications, it was really the children that were notified the most. You can see that 70 to 79-year-old with comprised of 3% of the notifications. So that's a huge component in the childhood sphere. And so that's why we think, and then this conversation article came out around that time saying that Australia faces another record flu season and children's vaccination rates are alarming. And I'll go into why they wrote this in 2 slides. Okay, so is this because, so we always think about now, what was last year? Was it a good match? Did the vaccines actually work? Or did we have circulating strains that were very different to the vaccine? And so poo-poo, the vaccine didn't really help. Well, when we've analyzed the data, it looks like, yes, it was a good vaccine match. So the antigens within the vaccine were similar to what was circulating around. And when you do vaccine effectiveness, we looked and we said, yes, it did present people who were vaccinated, it helped them, so 64% against GP presentation and 68% against hospitalization. And so, yes, it did work when people were vaccinated. And so now the second question comes up. Well, then what was the vaccination coverage? Because it's not a vaccine that, protects someone. It's the fact that they're being vaccinated. And so when you look at this, and this was produced by NCIRS, you can see that in New South Wales, really, it was the people above 65. Yes, we got 60% coverage, right? But everyone else, it was quite dismal. And from 6 months to 5 years, where it's free, it was only 26% of the population. And, that's in keeping with the other states as well. So it's not a competition, but we can see there that, that group comprised of a large proportion of notifications. And so perhaps to decrease that, we need to kind of get them in to be vaccinated. And then when you look at people of Aboriginal and Torres Strait Islander, the number is even lower in terms of the young. So it's at around 18%. So, so this year we need to really convey that to our population. I think it's not because of you guys in terms of immunizations, I'm speaking to the converted, but there was probably a lot of vaccine fatigue after the pandemic. And so now we need to kind of rethink, okay, how do we message that, last year it was mainly the kids that made most of the notifications. And so we really need to kind of push that vaccine to the kids as well as people with comorbidities and our older Australians. Okay, so let's get back to the Sullivan family. It's March 2024. Now, Nushin, she's 35 years and is 25 weeks pregnant with her 4th pregnancy and her 5th child, because you'll remember that she's just, have 18 months twins. Her husband, Mark, is 40 and he's got diet-controlled diabetes. And they both have a healthy 15-year-old son, Ethan, 11-year-old daughter, what was her name, Maya, with mild asthma, and 18-month-old twins. And if you think about, and her mother, Maria, has been recently diagnosed with rheumatoid arthritis and is on a DMARD, perhaps starting a biologic agent, and her father has some, BP medications and a statin for high cholesterol. Whoa, that's huge, isn't it? Like when people just kind of come to you and the entire family and you have to sort them all out. But let's think about the flu vaccine in this family, especially because they're so proactive. So another question for you. And sorry about little, not elderly Ron, who never kind of gets there, but his name's Ron, he's 35. Who and you can choose more than one, and please do, is recommended the flu vaccine? Please start. I give you 30 seconds because otherwise I won't be able to get through all my immense amount of slides. So get clicking. Okay, for a little bit longer. Perfect. We've reached 100. So I'm just going to end poll in the interest of time. And yes, I like it. Almost everyone got a blue line. And really, I just want to reiterate that, oh God, what happened there? Yes, everybody is recommended the flu vaccine. So we want to vaccinate the entire population, perhaps apart from people who get anaphylaxis from the flu vaccine, but that's a very minority. So everyone is recommended. So now there's another question. Who is funded under the NIP? And I just wanted to, oops, sorry, that wasn't supposed to show, just flagging that this family is not of Aboriginal and Torres Strait Islander background. All right, good. Let's see what the poll shows. So Mark, Nushin, we've got Maya, Arash, Elnaz, Maria, and Ron, and poor Ethan is just standing there on his own. All right, let's have a look. So in fact, everyone but Ethan and Maya are funded. And I'll tell you why about the mild asthma, because I find that a little bit confusing. Oh gosh, sorry, what's happened here? Apologies, don't know what's happened with my PowerPoint, but I will restart. Open recent. Okay. Zoom, share, that one, share. Okay. Oops. Sorry, I got too excited. Maybe PowerPoint just went a bit funky. This is really weird. Okay, all right. Yeah, and so in fact, you know, asthma is a comorbidity that I find kind of hard to read, and we'll go through kind of the ATAGI statement. So this is the ATAGI statement. It was recently released in early March, and it's only, fortunately, 2.5 pages, so it's pretty easy to read. And in there, it says what will be available for free on the NIP, and it's in for children 6 months to 5 years. And I've got a diagram that's imported from that ATAGI statement. And so you can look at that. So it's Fluorix Tetra and then Vaxigrip Tetra. And then for people medically at risk between 5 up to 64 years, there's the usual 2, but also Flucelvax Quad this year. And then over 65 years, we want our Fluad Quad. Okay, so as you all know, it's recommended and funded for children aged 6 months to less than 5 years and everyone above 65 years, and all Aboriginal and Torres Strait Islander people, and then all people who have certain medical conditions, and all pregnant women. All right, so this is the table that's in the ATAGI statement, and you can find it in the handbook as well. And in terms of chronic respiratory disease, it says severe asthma. So in fact, mild asthma, you know, for someone who takes the salbutamol inhaler every now and again, it's if you read it, it's not funded, but it does say there that like it's up to kind of the clinician discretion as well. Okay, so a next question is Nushin is now excited to hear about the different types of flu vaccines and asks which flu vaccine should she get, the cell-based or the egg-based? And you can pick one or more. Don't know what I've done on this one. Good. Everyone's like really onto it after like my technical error. Let's see if we can get to 100 votes before 30 seconds. Oh, 23 and we reached 100. Awesome. You guys are the best. Okay. All right. So it's, I can share that. It's egg-based. Some people are egg-based, but mostly everyone said either. Good. All right. Let's close that and let's look at what it just disappears and whenever I click. All right. So it's egg-based or either, both of that's correct. Now I'll go a little bit more about cell versus egg-based vaccines. And there are some theoretical advantages of cell-based vaccines, and that's why we're kind of we're starting to introduce cell-based vaccines. But there's no preferential recommendation for its use over standard influenza vaccine. In our FAQs, you'll see, an NCIRS FAQs, it says that standard influenza vaccines are currently preferred for use in pregnancy because there's a large body of evidence that supports their safety in pregnant women. Okay, while the use of cell-based influenza vaccine in pregnancy has not been assessed, there are no theoretical concerns regarding their safety in a pregnant woman. So I read that to say there's more data around eggs, so perhaps that's preferred. If someone really wants cell-based, then that's fine. It's funded. Okay. So let me just see if it comes up. Yeah. All right. So we have, again, the egg-based and the cell-based, but what we don't have, and people might come and ask, is the recombinant vaccine, the flu-bot quadrivalent, and the live attenuated intranasal vaccine. So we don't have that in Australia. And why are we kind of going cell-based? You know, it's because there are lots of advantages in manufacturing, okay? So there's a shorter production time than egg-based, and it leads to better matched viruses, because what happens is that we inject the egg with the virus, but as it replicates, it's an RNA virus, so it's prone to lots of mutation. And so sometimes what comes out is slightly different to what you put in, right? But in a cell, it seems you have more control over that. And you're able to like pump out a lot more in a very short amount of time. Okay, but at the moment it's still quite expensive, and it's a new platform, a newish platform, and so we're just getting used to it. Okay, so this is that beautiful table that you would have seen in last year, and it's again in this year's ATAGI statement. And what's new is the Flu-Sol-Vax quad. And as with last year, white means it's funded by the NIP, and grey is it's available in the private market. Tick means yes, it's allowed, like it's registered for that age group, and cross means it's not. The other difference in this table to last year is that the registered age group for Flu-Sol-Vax quad, so the cell-based vaccine, has decreased to 6 months. So if you bring out your old kind of like Crumpool 2003 guideline, you'll see that it's 2 to 5 years. But now we have more international data on its use in 6 months to 2 years, and so it's registered for that. But it's not free. That's not the one that's provided for free in that age group. Okay, so we have another question coming up. So Arash, he is 18 months and he has developed a rash and eczema with egg. What is your recommendation? Do you advise against the flu vaccine? Do you vaccinate with an egg-based vaccine? Do you vaccinate with a cell-based vaccine? Or do you refer to a specialist immunization clinic? So let's get this to 100 before 30. We're on 20 seconds. We need 40 more votes. There's no wrong, like, oh, we're up to 101 as 34 seconds. All right. Do you feel like you're at an auction? Anyway, so I need to share the results first. So fortunately, very few of you advised against influenza vaccine. And then the majority said, why not give the cell-based influenza vaccine? And then a large minority said, just vaccinate with the egg-based, and some would refer to the specialist immunization clinic. And I think that's kind of quite proportional to how like people, practitioners around New South Wales think. All right. Well, I'm here to tell you is that, yes, you can vaccinate with an egg-based vaccine and you can vaccinate with a cell-based vaccine. But I'd probably vaccinate with egg-based because it's free, but if a mum is very concerned and it's all a little bit too much, they can pay for a cell-based flu vaccine. And I just want to bring you back to this beautiful fact sheet that was produced by ASHKIA, which is the Allergy Society of Australia. And they've done so many, they've looked at quite a few studies, over 4,000 egg allergic patients, and they found that really they don't get anaphylaxis to the flu vaccine. And the reason is because in the flu vaccine, there's kind of less than 2 micrograms of egg protein perhaps left. And for people to trigger a reaction, you need at least 130 micrograms taken. So in that sense, now what we say is that even if someone has egg anaphylaxis, you can still vaccinate with an egg-based vaccine. But, some consumers might get really twitchy about it. And so there is that cell-based vaccine that you can offer. All right. So now we're going to Maria and Ron. And poor Ron, his age just disappears. Oh, there he goes, back again. So there's a question. So which vaccine would you recommend them? Okay. So let's get to 30 seconds. And I think you can choose one or more. All right, good. Okay, let's share your results. So most of you said the Fluad Quad, and some of you said the Fluzone High Dose Quad, and there were a few that chose others as well. Close it. And yes, so I would want to, let me just say share results. Sorry, I don't know, stop sharing and I close. Yeah. I would want to, you could recommend, they recommended the Fluad Quad and the Fluzone High Dose Quad. And they're actually aware that, they should receive an enhanced flu vaccine because it's over or equal to 65 years. And yes, those 2 vaccines are available. The Fluad Quad is an adjuvanted vaccine, and the Fluzone Quad High Dose Quadrivalent is a high dose vaccine. But I'd probably be giving Fluad Quad because it's free via the NIP. But, again, if someone wants to pay for it or they're ineligible for funded vaccines, then you can get either. All right, so now they're saying, we've seen the charts, we review that weekly New South Wales kind of surveillance report. What about COVID-19? So now I'm going to pivot off to the virus that we've known so well for the past 5 years, 4 years really, SARS-CoV-2. So I've already shown you this. Even though it's 2024, we still have SARS-CoV-2 circulating. And in that report, it gives this beautiful kind of quite psychedelic picture that really shows which subtype is around. And at the moment, it's almost exclusively JN.1. But until recently, so until kind of November last year, we had a lot of XBB circulating, whether it was 1.5, 1.16, or 1.9. And so what are the vaccines that we have available? And because XXB was circulating previously, they've utilized that to develop a vaccine that contains that antigen in it. And so that is really the recommended vaccines that we want to give people as boosters. And what is the recommendation? Again, that's just come out this year from through an ATAGI statement. The handbook is still yet to be updated, just as an FYI. So if it's an older adult and adults with severe immunocompromise, then you want to give it every 6 to 12 months, perhaps every 6 months if you're on that severe immunocompromise, right? But you can see on the table that if you're kind of under 65, then it's recommended every 12 months if you have a severe immunocompromising condition, but only consider a dose every 12 months. Perhaps someone's flying to a wedding somewhere, or they really can't get sick, or they're fed up of kind of having to stay home. They've got an important something coming up. Then that's might be a time that you want to give it. Or someone who's a little bit more brittle, you might want to kind of consider it. But you can see here that under 5, it's not recommended, even if you have severe immunocompromise. And the 5 to 17-year-olds, if you don't have severe compromise, it's not recommended. And if you do have severe immunocompromise, then you can consider it. But all that is very confusing. So poor Maria is confused. She's just like, that makes no sense to me. I don't understand, doctor or nurse. I've just had rheumatoid arthritis diagnosed, and I've been on high-dose steroids, and I'm on a DMARD, so a sulfasalazine, and my rheumatologist has told me that I might be starting some biologic monoclonal antibody that might immunosuppress me. Does that mean I need 12 months or 6 months? And so what is a severe immunocompromising condition? Well, according to Atagi, it's really people that have quite depleted immune system. So hematological malignancy, solid organ malignancy or transplant, and inflammatory conditions treated with biologic agents or conventional immunosuppressants at significant doses. If you're an if you're a person living with HIV with a CD4 count less than 200, if you've got a primary immunodeficiency, or if you're a chronic kidney disease on dialysis, those are the ones that they would classify as being every 12 months with and can consider a dose every 6 months. And so perhaps she at the moment kind of falls in the consider, but I would just err on the side of what you think is best. If you think someone is not going to do too well with COVID, then just give it. Consider just doesn't mean that it's not, you can't give it. It's just, it puts kind of the onus really on the provider to say, we know that people have been vaccinated multiple times, they've been infected multiple times, you've got pretty good hybrid immunity, and it's likely that, 1 dose per year might be enough. But if you're a little bit more concerned, then 1 dose every 6 months. Okay, that's how I like to say it. Now, who doesn't need a COVID vaccine? So if a child aged 0 to 17 without a severe immunocompromising condition hasn't received a primary vaccine series, so hasn't had any COVID vaccines, they really don't need a vaccine. And there's really good data to suggest that a large proportion of our population have been infected multiple times, and they've done okay in that kind of cohort age group. If it's an adult who's over or equal to 18, and hasn't had a COVID vaccine, then they're recommended a single primary dose. So I think you'll have the slides and the video available. So I think this slide is quite important, and it'll be reflected in the handbook update. And this is something that was shared to me by Lauren. It's a beautiful, where's the actual, there it is. It's a beautiful poster. It's an A3 poster that you can put up in your clinic, and it's all color coded because different vaccines for different age groups have different colors and with different kind of antigens, so it's all a little bit like really confusing, but you guys are amazing, and you guys do so well, and I'd recommend printing out this poster and putting it up. All right, now I'm kind of halfway through time, or 40 40%, not 40, 60% through the time. And let me see. Yeah, okay, that's fine. I'm going to move to RSV. So the family have had several relatives recently diagnosed with RSV, because you've seen the burden, it's ticking up. And so some kids are coming in, with RSV now. And Nusen is very well read. Right, she's read these articles, and she's scared about bronchiolitis, especially for the newborn due in several months. So these are all the articles that she kind of finds on Dr. Google and on the SMH, and she's just like, tell me about these preventative measures. Okay, so welcome to RSV. RSV stands for respiratory syncytial virus. It causes disease, and you need, hospitalization in young children. So you can see on the y-axis is quite different to the graph on the left-hand side with the children versus the graph on the right-hand side, which is kind of adults to older adults. So it's biphasic. It peaks in the young, in the infant age group. And, it's, as a pediatrician, we get scared of RSV season. They come in and very sick, they've got bronchiolitis, they don't feed, they're huffing and puffing, it's awful. But we now know that it does affect older Australians or older adults as well. And, and this is through that increased testing. And we now know that a fair proportion of people coming into hospital with a pneumonia, it might be RSV in older adults. And there are long-term effects of RSV illness. Kids that get RSV, they're at higher risk for non-atopic asthma. So they get this kind of wheezy episode that goes on for a longer time. And we know that we can prevent that kind of wheezing episode when children are treated with a monoclonal antibody that we have been using against RSV called palivizumab. And so I'm just going to skip this slide because we know I've shown it and you've seen this slide before. So what are the RSV prevention strategies that we have or that will come? Okay, so I now want you to think about the older Australians and the little infants. So to protect the older Australians, we have Pfizer Arexvy is they're currently submitting to the TGA. So it hasn't been TGA approved, but it is approved overseas. In terms of protecting our young, like little infants, is just like pertussis and just like the flu, we can vaccinate the pregnant women to produce passive antibodies to protect their infant, okay? And that's a vaccine that's registered elsewhere overseas is the Pfizer Arexvy vaccine. It's an adjuvanted vaccine, but it's not yet registered in Australia. And then we have a long-acting immunoglobulin called nirsevimab. And you give that, it's one intramuscular injection into the infant to protect the infant over the first RSV year. Okay, so this is a little bit kind of more, my things get a little bit more technical, but I think it's really important because when the RSV virus comes in, pre-fusion, it looks like a little knob. That's not the virus. That's the little protein that's sticking out of the virus. But when it fuses with the cell, it elongates, right? And so what you want to do is you want to protect the person with antibodies that will clasp the pre-fusion before it links into our respiratory cells, right? And you can see the pre-fusion RSV protein is quite colorful. There's a red and a yellow and an orange, right? But then the post-fusion RSV, so when it's connected, those sites involute, right? And so it's not there anymore, right? And so what we're trying to aim with these preventative measures is to produce antibodies against the red, and the palivizumab already produces antibodies against the yellow, against the antibodies against the orange, but not antibodies against the purple, green, and blue, okay? So that's kind of what we want to do. And this is the pathway. I'm just going to skip through it because in the interest of time. And we now have an ATAGI statement for adults or older adult vaccination. We don't have any kind of national statement on the infant vaccination program. Okay, all right. So why do we want to vaccinate older adults? Well, blue is placebo in the graph, right? And there are people who didn't get vaccinated. And then yellow or orangey is burnt yellow is what I would call it, actually burnt yellow, as those who've been vaccinated. And you can see there's a stark difference in incidence, right? And so, yes, the vaccine works. It works against hospitalization and it works against disease. So it's great and we want people to use it. But as with all vaccines, we need to think about what are possibly some serious adverse events following immunization. I don't have a slide on just the kind of the solicited side effects, like when you go get a vaccine and you go in and then you get it and then you get like a local reaction and you get a bit of fever and you're sick. All that is on par kind of with other vaccines. But what has come out in the clinical trials is that there were 3 or 4 extra people who developed inflammatory neurologic events in people who were vaccinated versus placebo, all right? 1 was Guillain-Barré, and so it's 3, sorry, and 2 were ADEM, so acute disseminated encephalomyelitis. What does this mean in terms of the larger population? We don't know, but it means that we need to keep an eye out for it, right? And then interestingly, 10 participants reported atrial fibrillation, so where the heart the rhythm just pulsates within 30 days after that shouldn't say infection, that should say injection of the vaccine, versus 4 who were injected with a placebo. So there seems to be a slightly higher kind of perhaps risk of AF, maybe. And so again, we need to monitor. And so this is a beautiful slide. It's made by the US CDC, and it shows that per 1 million vaccine doses administered to adults aged greater than 60, you're going to prevent, let's look at GSK because that's what's registered at the moment, but Pfizer will hopefully be registered soon. So 23,000 outpatient visits you protect against. Sorry, you protect against 2,400 hospitalization, you protect against 450 ICU admissions and 120 in-hospital deaths, with perhaps an excess of around 5 GBS cases, okay? Because 5 would probably be expected from background, and then 5 extra perhaps in that group. So I think that's really important to take away, is that there is that tiny bit of risk, and you need to be able to kind of explain that to your patients, but overwhelmingly the benefit seems to be a lot more. I'm going to skip the slide just in the interest of time, but again, it just shows that that it has a huge benefit and we need to monitor for the risks. Okay, so who is it recommended against? So it's recommended for all adults aged 75 years and over. It's recommended for all Aboriginal and Torres Strait Islander people aged 60 and above. And it's recommended for all adults aged 60 and above with a medical condition that increases their risk to severe disease due to RSV, and those medical conditions are included in the ATAGI statement, and I have it on my next slide. Okay, and all other adults 60 to 74 years that are non-Aboriginal or Torres Strait Islander and don't have a medical conditions can consider an RSV vaccine, but the burden is a lot lower in that age group than in people over 75. So these are the medical conditions, and you can look at that kind of later. But I just want to flag that it's not available on the NIP. It's a private market prescription. It looks like now, I looked on the New South Wales pharmacy prescribing website as well, and pharmacies it's within their scope of practice to also administer it. And I've heard kind of it costs around $200 to $300. So that's that. Another question that comes up is, will we have this as an annual dose, or is it just 1 dose and that's it, you know? And I think the data is evolving, but there is good data to show that it does protect into the second season, okay? There's lower efficacy, but there is still protection. All right, so now what about protecting infants? Okay. So I've mentioned this before, that you can vaccinate in pregnancy, and there's only the Pfizer Abrysvo that's been approved by the FDA and European Commission. The GSK Arexvy, they did a study in pregnant women, but they stopped it early due to increase in premature births. And what did the Pfizer vaccine show? It showed that it protected against severe disease up to 90 days at around a vaccine efficacy of 80%. So that's huge, right? That's absolutely huge. And up to 180 days, it still had an effect. So against severe disease is 69%, and non-severe disease around 50% protection. So I think that that's a huge kind of burden of disease. If anyone kind of works in pediatrics, that they'll kind of understand the absolute numbers of all that. All right, so it's well tolerated, but again, this vaccine, there seemed to be a trend towards premature births, okay? But when they looked at it in more detail, and I don't have like graphs and pictures from the paper because it's just a bit like overwhelming, but it looked like it was confined to upper middle income countries. So the premature births were occurring in places like South Africa and Brazil, and not places like the USA or other places in Europe. Okay. And so if you stratified by country's income setting, there seemed to be no difference in premature births. Importantly, they didn't find any of that inflammatory neuropathy or atrial fibrillation. And there was no increase in allergies of the infant of vaccinated mothers at 24 months. Okay. But because of that kind of premature birth, slight concern, different jurisdictions overseas have registered the vaccine for different ages. So you can give the vaccine from 24 weeks onwards, but in the US they've said for the first season, let's just go from 32 weeks onwards. In the UK they've said let's just give it from 28 weeks onwards, and the European Union said no, it's fine for 24. But each country within the European, for example, like Belgium or something, will give it from 28 weeks onwards. So we'll see what the recommendations are for Australia. But I suspect it'll probably be around 28 weeks onwards for the first season. Okay, you can give it with other pregnancy vaccine. There's good data, and there is no difference in solicited adverse events following immunizations. When you look at the immunogenicity, perhaps it was non-inferior for tetanus, and pertussis seemed less immunogenic than if you gave the DTaP with the placebo. But we're unsure of the clinical relevance, and it's probably just a better idea just to kind of give it all at once. All right, so I am now going to talk about the long-acting monoclonal antibody, and please, others who are convening as well, kick me off when I've needed to be kicked off. So this is nirsevimab, okay? So what is nirsevimab? No one heard of palivizumab, but now everyone's hearing about nirsevimab. All right, so it's a monoclonal antibody, and it has an extended half-life, so it's pretty cool. So what they did is that they changed the lower half of the antibody to be really robust. So that meant it, instead of lasting a month, it could last 6 months. And so it kind of acts like you inject it like a vaccine. And it is immunization, but it's passive immunization, right? So it doesn't require the infant's immune system to develop immunity. You're just giving an antibody that will mop up the virus before it causes infection, okay? And it works really well. And so here's a good graph that shows again, this time the yellow or burnt yellow is the treatment, so babies who got nirsevimab, and blue is standard care. And you could see that on the y-axis is percentage free from hospitalization. So the higher it is, the better. And what about the real world? Well, we've got this. This is from Spain, and if you go to this website, it's kind of cool. It gets updated every kind of week, and it shows that season 2023 to 24 is in orange, and the other seasons are in the respective kind of cool colors, And this was a rollout of this nirsevimab to all infants in that region. And the season looks markedly different to the prior seasons in terms of hospitalization. So it looks like it's a highly effective preventative therapy. And if you reside in Western Australia, they've done a deal. And so all babies under 8 months in Western Australia get it for free. And babies who might be at higher risk of severe disease can get it I think up to 1.5 years of age. So that's just recently come out, and we'll see what happens in other states. But at the moment, there's no release to say that it's funded. Okay. All right. So now I'm going to go to the other tidbit vaccines that you all have had experience with, but just as a reminder. So this is Nushin's friend, who's an immunization nurse, and she mentioned a new, or now not so new, vaccine called Vexelis. So which vaccine is Vexelis most akin to? Lovely. It looks like people have already started voting. Come on, you can get clicking. We can get to the 100 mark. I know it's like 10 minutes to 8. All right, we're at 40 at 87. All right, I'm just going to end poll now. So the majority are correct. It's akin to Influenza hexa. Sorry, share results. There you go. And then we'll close. All right, so Influenza hexa. Oops, I don't know what happened there. All right. So this is just a quick reminder. Vexelis is around. It was approved in 2022, so it's been a while now. It was added to the NIP from July last year as an alternative to Influenza hexa. It's 0.5 mils IM pre-filled syringe. You don't need to reconstitute. It can be given at the same time at every kind of vaccine that you'd otherwise use Influenza hexa. And the only contraindication is history of anaphylaxis to a vaccine component, which is the same for any other vaccine. It's been widespread. There's widespread use in other countries. And just as a reminder, what's the difference between Influenza hexa and Vexelis? It's just that in Vexelis, we have 5 pertussis antigens, and there are only 3 in Influenza hexa. Is it better? We don't know yet. It seems like of the 5, the quantity is lower of each vaccine in Vexelis, but is it worse? We don't know, but it looks like it's kind of on par. Importantly, from a practice point of view, Vexelis can be interchangeable with Influenza hexa. So if you give it at 6 weeks, Influenza hexa, you can give Vexelis at 4 months, and it can be co-administered with NIP vaccines, including Bexsero. And I say Bexsero because you would have noticed that on here, it's the PRPOMP, so the outer membrane protein of meningococcal B, but it looks like it's absolutely fine, and you can give it with Bexsero. Okay, that was just so much information, and poor Notion is saturated. She thanks you and heads off for her glucose tolerance test appointment, and you look at the NIP and you realize that one of these vaccines are no longer funded. There should be a poll coming up. Which one is it? I'm just going to give you 15 seconds because I'm probably going to be booted out soon. Oh, good. Got to 90. Yeah, good. Okay, got to 100. So I'll share. And yes, you are correct. It is pro-quad. So just as an FYI, that's not funded. Still works, but you probably don't want to people probably don't want to pay for it. Okay, and just as a reminder, we have measles in Australia. There's been a measles alert for Sydney in February, and just I think last weekend a measles alert in Melbourne. So it's really important that we still kind of advocate for the measles vaccine, and we give it at 12 months, but you can give it earlier if traveling or are in an outbreak. Okay, so Nushin is gone. But Marie and Ron, however, have more questions. Now they're hoping to hire a caravan and drive across Australia. So they're really proactive, and they want to ensure that they have all the jabs they require before they embark on this journey. And I think the cartoon says that if it's the Pacific Ocean, let's have muesli and orange juice. And if it's the Indian, well, it's deck chairs and wine and nibbles. All right. One day we'll get there. All right. Maria remembers her mother having shingles. It was painful, and she developed herpes zoster ophthalmicus, which is an absolutely awful complication of shingles. And it's something that I've treated as an infectious diseases physician, and it can cause blindness. So what causes shingles? It's a reactivation of the chickenpox or the varicella zoster virus. And you get pain, then you get a flat rash, then you get a vesicular rash, then it crosses over, and it's usually dermatomal because it lives in our ganglion, and it's pretty awful, and it hurts a lot, and you can get residual pain. Why does it occur? Well, it's because it requires T-cell immunity to suppress that virus. It's in our body, we're just suppressing it. Antibodies and B cells are not protective. And as you grow older, there's this phenomenon called immunosenescence. So your immune system weakens it with age. And that's why with the flu vaccine, you want to give them a adjuvanted or a higher dose, right? And so risk factors are increasing age, immunocompromising conditions, especially where the T cell functions are affected, right? So hematological malignancy, HIV, stem cell transplant, and people on immunosuppression. All right. Triggers such as stress and intercurrent infections can also trigger shingles. How commonly does it occur? There's a lifetime risk of 20 to 30%, and 50% of 85-year-olds will have had shingles. And so the annual incidence isn't insignificant. You can see this graph that it really goes up with age. And so we recommend the vaccine in older Australians. And we have moved on from Zostavax. It's a recombinant Zoster vaccine called Shingrix, which I'm sure you've all given. And it has that AS01B adjuvant system you'd remember, same as the one in the RSV adjuvant vaccine. It's registered from 50. It's a 2-dose schedule, 2 to 6 months, but only 1 to 2 months in the immunocompromised. And you can see which population it's funded in. I'm just going to skip this, but what it shows is that it's a pretty good vaccine and it's better than Zostavax. And really, we have it because one, Zostavax is live and could cause disseminated zoster in immunocompromised host. And Shingrix is just a better vaccine, so it lasts for longer. Okay. Yes, so these are some of the practice points, and I'm going to skip through it. You can kind of read through them. But I guess the one thing I wanted to highlight is that when you have shingles, you can probably delay the vaccine by 12 months if you're immunocompetent, but 3 months if you're immunocompromised. If you've had Zostavax, just so that, you get better coverage, because Zostavax will work, quite well for the first 12 months, gives Shingrix 12 months after. Okay. Oh, and the other thing that comes to us is that you don't need to do serology, okay? Because most people in that age group would have come across chickenpox, so you can just give the Shingrix vaccine. You don't have to do varicella serology. Okay, so Ron's asking for a friend now. His golf mate Simon, living on the northern beaches, has gotten bitten by a tick and developed mammalian meat allergy and is concerned about getting Shingrix, sorry. So you agree to chat to Simon separately, because it's not good to talk about friends to, other people about his medical issues, but you think to yourself, can Simon get the vaccine? And I think there's a poll. Is there a poll? Yes. So please click. It's a tricky one. And the reason I put it in is because it was a question that came to NCIRS this week. And I thought, oh, that's a good one to talk about, because it's a bit left field. All right, going to end poll. Share your results. So the majority have said yes. That's great. I'm going to stop sharing and close. So the answer is yes. And I just want to highlight this because there has been case reports where there have been anaphylaxis after the Zostavax vaccine. And the reason why is because the Zostavax vaccine contains gelatin, right? So what is mammalian meat allergy? It's also called red meat allergy or alpha-gal syndrome. And it's where you've bitten by a tick and then suddenly you develop an anaphylaxis to all these meat products. And there's lots of, it's actually quite fascinating in terms of the pathophysiology, but don't have the time to go through it. But in this article, it also showed that, gelatin content of the vaccine of Zostavax is much higher than any of kind of the even MMR and yellow fever vaccine. So that was why the concern, because it's been like the gelatin within the Zostavax could potentially, trigger anaphylaxis. But fortunately, you look up on the Australian Immunisation Handbook and there is no kind of animal protein in Shingrix, so they can safely be given Shingrix. All right, so HPV, Maya, she's starting year 7 next year. She's very excited as her friends are going to the same school. She's, however, wary of school vaccinations and never enjoyed getting the annual flu vaccine, but nervous. Now, how many doses of HPV is required in 2024 onwards? All right, that was good. Okay, end poll. So share results. So the majority have said 1, some have said 2, and a minority have said 3. Okay, stop sharing. So the answer is, oh, what's happened? The answer is, oh yeah, I don't have the tick. The answer is 1, okay? So it's a single dose schedule. And there is really good data, and this is data that was kind of compiled overseas in low and middle income countries where they vaccinated against 1 dose, and it was shown to be just as protective. And I think that's really exciting, not only for Maya and her friends, because they don't have to have a second jab, but also globally, because now the HPV vaccine is a lot better, can be better afforded by countries because they only have to give 1 dose. And there's a brilliant fact sheet that can be accessed on this link. It's from the health.gov, and it talks about the key points that changed the program. All right, so my gosh, there are so many vaccines in pregnancy and or older adults. Can they be co-administered? Yes. There is no vaccine that we would suggest that you can't co-administer. There was some concern last year about Shingrix because it was quite an immunogenic vaccine. So people used to get reactogenic, So people used to get a bit like, kind of feel a bit off afterwards. So there was some suggestion that, you can maybe separate it from the flu, but that's no longer the recommendation. You can separate it or you can just give it at once. All right, I promise now we only have a few more slides left, and I think I've completed all the questions, but really it's about how do we improve uptake. And it's all about you guys. I'm speaking to the converted. You need to know your community, and you guys do. We know that, influenza vaccine, but other vaccine uptake really relies on people's knowledge, awareness, beliefs, attitudes, and social influences. And so if you can address all 3 of those, then, you're able to kind of bring people in. But those 3 are very different where you work. I know I'm talking to kind of the eastern inner city and Sydney, but even there's such different and diverse communities in terms of the pockets in which where you work. But the most important thing is that healthcare providers make a difference. Time and time again, it's been shown that healthcare providers, so yourselves, play an important role in vaccine uptake. And when we're talking about our Indigenous communities, this was an article that was beautifully written by some people that work at NCIRS. And what they did is that they interviewed immunisation providers, and the themes that came out were really support your Aboriginal medical service, improve accessibility and appropriateness of mainstream services as well, improve healthcare knowledge of Aboriginal people's influenza risk, and engage communities to design their own influenza vaccine resources. And so this is a great web link for you guys to go to on supporting conversations. And it was actually written in consultation with Indigenous people, and they kind of came up with these phrases. And so there's a beautiful fact sheet that you can go through, and it really talks about from people of Aboriginal and Torres Strait Islander telling us as providers, this is how you engage with our community. And it also gives you tips on what else your service can do. And lastly, Sky is a brilliant, again, website that you can go to, and it talks about sharing knowledge about immunisation. You can give both yourselves and your clients some resources as well. So I hope this works, but are you guys now overloaded? Well, if you're overloaded, my take-home message is all that I have said can be found on the internet. You can go to New South Wales Health. There's all the resources there, and it's a wealth of information. We have resources on our NCIRS webinar. So we've done a webinar on the RSV vaccine and antibody in infants, and we've done a webinar on RSV and older adult protection. And the records, I don't have it here. The recording are available in that link. And our flu and COVID vaccine update is coming on the 27th of March. So tune in. We also have a myriad of fact sheets, and they're being updated. So RSV and COVID-19, I think the RSV and COVID-19 have been updated, and the influenza is being updated as well. And we've also got really important FAQs on Vexelis and Shingrix and kind of every VPD, really. And I work for NCIRS, and this is our email. You can email us with any clinical advice, for clinical advice. And we also have an urgent after hours advice number. And lastly, to leave you, the Sullivan family thanks you for your time and effort in keeping them safe from nasty diseases. So thank you very much.
Thank you, Dr. Archana. That was an amazing presentation. Lots to cover. So I thank you for getting through it all almost within the hour. That's amazing. We do have a few questions if you've got some more time available.
Yes, I do.
So our first question that came up when you were talking about the COVID vaccines is to do with a 78-year-old patient traveling to Greece in May, had her fourth COVID vax the end of November. Should she have another vax before traveling? There's only a 5-month interval.
Yeah, sure. Good question. I would suggest that she probably doesn't need it. The only thing is that she probably got a different bivalent vaccine, compared to the XBB, but we've also moved from that. So I would suggest to kind of keep it to the 6-month mark, and also ask if they've had infection recently. Yeah.
Perfect. Thank you. Let's do this one. If a patient under 17 years of age and immunocompetent had the first dose of COVID vaccine before the 2024 COVID vaccine guidelines came out, would the single dose be sufficient, meaning they no longer need a second primary dose? So yeah, that's related to that new the new guidelines that have come out this year.
Yes, that's right. So as I read it, that is correct. Yes, because they've had a single dose. Now, what about medical students who are 17 years of age, never had COVID vaccines, but need COVID proof of vaccines as part of their clinical compliance for their clinical placements? Yeah, that's a really good scenario. And I'm going to take it back actually to the NCIRS group. But I suggest that in that setting, you probably, because they're in a setting where they need to protect, it's not just for themselves, it's to protect the cohort that they're working with, that they should get vaccinated.
Excellent, thank you. Is nirsevimab even given even if the mother has not been vaccinated while pregnant?
Yeah, good. That's a really good question. So I just want to clarify that the mother's vaccination, so the RSV vaccine given in pregnant women, is to produce antibodies from mum to pass to the babies. So when the baby is born, they've got all these beautiful mother antibodies from mum that protects them when they're very young. Okay, that's what we're trying to do with nirsevimab. It's just that instead of giving it to the mum, we're giving the already produced antibodies to the baby, right? And so they kind of work in the same way. So if you've given mum the vaccine, you probably don't need to give nirsevimab to the infant, because the mum would have already generated the antibodies to give to the infant. Now, there are caveats where, mum got vaccinated today and baby got born tomorrow and is prem, so perhaps there wasn't that transfer of antibodies, but generally they both work kind of equally. And overseas, and in particular in the UK, if the mum has been vaccinated with an RSV vaccine, then we don't give nirsevimab to the infant. But there's also a thing where perhaps because it's not something protection that the infant has made themselves, so it's going to wane, right? And so is there a role for nirsevimab later? But that's a totally different conversation. But I hope whoever put that in understands that. Yeah.
Great. Can we use the same MMR2 to children of 12 months and vice versa? When it is government funded, is it the same MMR2?
The same MMR2.
I don't quite understand.
I don't. Maybe someone else can answer that question.
Yeah, if whoever put it in could maybe reword it to make the question a bit clearer. Thank you. I'll move on to, in the handbook, it says that if a person has previously received Zostavax through the NIP, they are not eligible to receive Shingrix through the NIP 5 years after the Zostavax dose.
Yeah.
But in the slides, you've said 12 months.
Yeah. No, I totally get you. And I'm so sorry. I probably should have flagged that. So it's not funded. until 5 years after Zostavax. But from a clinical standpoint, there is no need to give Shingrix less than 12 months after Zostavax, because you'll get protection from Zostavax. So why give it under 12 months, in an immunocompetent host? So it's, I guess, it's a conversation that you have with your patient. Some people are really interested in getting it because they've read all about it and they know that it lasts longer. But others, who don't want to pay for it, they're still eligible, but 5 years after Zostavax.
Yeah, so I guess the second part of that question is, should we be recommending the patients pay privately? I guess the answer is yes. If they are wishing to pay privately, you should be recommending them to, as it is a better vaccine. Great. So the next question, Prevnar 13 is recommended. Okay, I'm not really understanding that question.
Can't use Shingrix. Jessica said can't use Shingrix with Fluad Quad because of the adjuvant. I might come back to that, but I think the issue is that I think what they mean is that Shingrix is quite a reactogenic vaccine, right? And so and anything that's adjuvanted is also more reactogenic kind of than other vaccines. And so perhaps that's the reason, but I don't know why otherwise GSK would have said that. Lauren, do you have any idea? I don't know. I'll get back to you. I'll look that up and send it to Kira, and then Kira, you can kind of.
Great, thanks. And my colleague Mimi has also gone through and answered some of the questions typing. So thank you for that, Mimi. And if anyone attending wants to have a look at those Q&As, that's great. But I think we'll leave it there for now. And if there's any more questions, always feel free to send them through to us, immunisation@cesphn.com.au. And when they're too hard for us, we do pass them on to the NCIRS team, so to Archana. So yeah, thank you again, Archana, for your presentation this evening. It's been a wealth of knowledge and we're really grateful.
No problem. Thank you so much for the invitation and for everyone sticking around.
Great. So next up, we have a recorded presentation from Joanne Hominal, she'll be presenting on the latest updates to the Australian Immunisation Register. Joanne is a business development officer working with the AIR in Services Australia. So I'm just going to get my colleague Lauren to share this presentation now.
Hello everyone, my name is Joanne and I'm a Business Development Officer with the Australian Immunisation Register. Before we begin tonight, I would like to acknowledge the traditional custodians of the lands we live on and pay my respects to all elders, past and present, of all Aboriginal and Torres Strait Islander nations. I'd like to firstly thank you, Kira, for the invitation to present tonight. We are grateful to have the opportunity to run the attendees through recent updates to the AIR, provide information on the AIR educational resources available, and advise how you can contact us online and by telephone. The AIR was enhanced to allow collection of additional information about vaccine type funding and the route of administration. So from 1st of March 2024, the collection of this information became mandatory under legislative changes for certain vaccines. Vaccine type, which relates to funding, is now mandatory for all COVID-19, influenza, NIP, and Japanese encephalitis vaccines, where the immunisation and the information provider is the same. For all other vaccines, the vaccine type field is optional but encouraged to be reported if the information is known. Software developers are currently updating their products. For those vaccination providers whose software was non-compliant by 1 March this year, the AIR site is available to report this information. So on the screen is how the AIR site displays the funding types, and those options are NIP and Commonwealth, private or state program, antenatal should be selected for instances where an individual is pregnant and receives a vaccine, regardless of whether the vaccine is funded privately or under the NIP or state and territory program. Vaccination providers can only select one of the 4 options under the vaccine type field. So on 1 March, the route of administration field was introduced, and this information is now mandatory to report for Japanese encephalitis vaccines, where the immunisation and the information provider is the same. So this screenshot shows how the route of administration fields appear with oral, subcutaneous, intradermal and intramuscular as those options. The AIR forms have also been updated to reflect the change. As you know, batch numbers have been mandatory to report for COVID-19 vaccinations for some time now, given by another vaccination provider in Australia or that were administered overseas. This mandatory reporting requirement expanded from the 1st of March 2024 to include all influenza, NIP and Japanese encephalitis vaccines where the immunisation and the information provider is the same. So recording the batch number means that individuals have a complete record of their vaccinations. The register contains a complete and reliable data set, and there is traceability where an issue is identified with a specific batch of vaccines. The batch number is located on the vaccine vials and container. The serial number field has been removed as this is no longer a requirement. On the 11th of February, several vaccine codes were removed from the AIR and replaced with new codes. These changes have been made because of the introduction of the vaccine type and the route of administration fields. The vaccines with the previous brand names can no longer be submitted. So the introduction of vaccine type field means that NIP, non-NIP is no longer separated for influenza vaccines. So Fluarax Tetra on the NIP and Fluarax Tetra non-NIP is now Fluarax Tetra. A Fluria Quad NIP and a Fluria Quad non-NIP is now a Fluria Quad. Individuals who had one of the now outdated NIP or non-NIP flu vaccines recorded have had their histories updated to the new vaccine brand name. The introduction of route of administration field will differentiate the following vaccines. So changes to the Imajev or Japanese encephalitis vaccine. The Imajev 0.1ml intradermal is now just Imajev. Changes to Jynneos smallpox vaccine. So Jynneos 0.1ml intradermal and Jynneos 0.5ml subcutaneous is now Jynneos. We have recently made some updates to 3 AIR forms, and these include a reminder that COVID-19 medical exemptions can only be recorded for up to 6 months on the IM011 form. The addition of Bexsero for individuals 2, 4 and 12 months and Shingrix to the adult section of both the history IM013 and encounter IM018 forms. I will just take this opportunity to remind you that using the AIR site or software to record vaccinations is the preferred method and should be encouraged. Using that digital option means the vaccination data is available immediately in most cases. You can submit some forms online using the form upload function in HPOS messages. This sends us the form and any supporting documents directly to us. HPOS confirms the form has been received for peace of mind, and you will receive a reference number to use if you need to contact us. But it's important to note here, to upload a form on behalf of the provider that has signed the form, you must be either acting as a HPOS delegate or on behalf of a PROTA organisation that you're a member of. There is a single page infographic available on our Health Professionals Education Gateway, which explains the process in detail. So we encourage you to access and share this resource wherever you can. In December, the AIR responded to user feedback and introduced more choice about what vaccination information users display on their immunisation history statement. Users can choose to generate a full immunisation history statement, which includes all vaccinations recorded, or generate a statement that shows just your COVID-19 and flu vaccines only. Having both options available provides additional privacy around immunisation information where required, and particularly useful for people whose employment requires them to produce this information. AIR now has an enhanced version of the AIR 42A report, which lists individuals' COVID-19 vaccination histories in date order. The report no longer includes information about COVID-19 vaccines that are due or overdue, and is now simply an easy-to-use list of individuals and the COVID-19 vaccines reported, the date of administration, and any medical exemptions also recorded. It will also display a nil result for those individuals where none are recorded on the AIR. There is a live simulation available on our Education Gateway, which takes approximately 9 minutes and steps you through how to request the report, and it's really great for those visual learners. There is a new report called the AIR 43A report, and this report can be used by vaccination providers to extract and reconcile vaccination information that they've previously reported to the AIR. This report contains information about the individual they've vaccinated and vaccine details, such as the vaccine brand and the vaccine type. It'll be particularly useful to those pharmacists participating in the NIP VIP program, so that's the National Immunisation Program, Vaccines in the Pharmacy, which commenced on the 1st of January 2024, as it can be used to reconcile their claims for payment. We are hoping to be able to present some live demonstrations of the AIR reports to you in a future webinar. On the 16th of July 2021, Shingrix was added to the AIR as a non-standard vaccine for use as an alternative to the herpes zoster vaccine. The Shingrix vaccine was added to the NIP as a standard vaccine on 1 November 2023. This will replace the Zostavax, the existing NIP vaccine for shingles. 2 new COVID-19 vaccines were added to the AIR, Moderna Spikevax and Pfizer, on the 4th of December 2023. Verirab, or the rabies vaccine, was added to the AIR as a non-standard vaccine on the 13th of December 2023. Arexvy vaccine for RSV was added to the AIR as a non-standard vaccine on the 29th of January 2024. The Arexvy vaccine has been available to purchase on the private market in Australia from late February 2024. It will be available for individuals aged 60 years and older. I just wanted to touch today on data quality, in particular the common reporting errors we see and how they can be avoided. A recent investigation undertaken by the ABDO shows that of just over 1,000 adult flu vaccines reported for children under 5, that 75% of those had simply been recorded incorrectly on the air and could have been prevented with some simple checks. Those checks are checking the software has not defaulted to the previous vaccine recorded. We have instances where hundreds of incorrect vaccines have been transmitted as the software defaulted and the operator did not update that field. So we asked users to investigate if their software has this function, and if so, educate staff on remembering to turn it off, or better still, see if it can be disabled. This may save time in the short term, but errors are time consuming to fix and data quality is very important. It's super important to encourage citing of a patient's Medicare card number, paying that special attention to the individual reference number. So we have lots of incorrect vaccinations coming through for the wrong sibling on the same Medicare card. There are a lot of vaccinations being reported outside of the appropriate age ranges. So ensure vaccination providers are aware that some vaccinations are not suitable for some age groups. In particular, this year we saw a lot of vaccination providers lodging Fluad Quad to under 65s, to which it is not recommended for. Pay that close attention to similar sounding vaccine names. There are a lot of drop-down options to choose from, so easy mistake to make. One of the most common vaccines that gets selected incorrectly is Fluad Quad when it should be Flu Quadri. If users do record an incorrect vaccination, we strongly encourage it to be amended ASAP. This can be done in several ways. Using the AIR site edit encounter function, using your software, noting not all products have this function, by requesting an amendment by emailing us securely using HPOS messages, or by calling the AIR on the provider line. The number will be at the end of this presentation. A few important things to note. If updating the encounter through the AIR site, the user must be logged in under the vaccination provider number that reported the encounter to have the access to update the encounter, either as the health professional's delegate or on behalf of the proto organisation if reported under an auxiliary AIR provider number. Secondly, if the encounter has been paid, so completing a schedule, the vaccination needs to be edited or removed by AIR staff. And thirdly, super important to know, completely deleting an encounter from software does not delete it from the AIR. So in this case, you would give AIR a call to delete it. We have various resources to help and educate health professionals on our Health Professional Education Gateway. This can be found by searching for Services Australia, HPE, on the Services Australia website, and the AIR tile is top centre. NCIRS and the PHN ISP also have some great resources, including a series of AIR tips that are proven to be really, really popular. We encourage you to provide ourselves or Lauren Dalton at the PHN ISP with ideas for future resources or topics for AIR tips. On our screen here are our Services Australia contact details and links to the education resources. And finally, I'd like to thank you all for your time today. We look forward to engaging with you again in the future.
Thank Thank you. And we have Joanne online to answer some questions now. If we can change vaccines to another, we can change another vaccine if we enter the wrong vaccine. However, we cannot delete the vaccine and have to call AIR to delete for us. Why is that? Joanne, just need to unmute.
Okay, you can hear me now?
Yeah.
Yeah, okay, sorry. Did you just have a question then? Could you repeat that? Sorry, I didn't hear. I had to...
No, that's okay. So if we have, we can edit a vaccine that's been entered into the air. However,
Yes.
we cannot delete a vaccine, and we have to call AIR to delete for us. Why is
Correct.
that?
Correct. That is because the AIR site doesn't have that function to delete, obviously, and a service officer would be able to enter into that record and proceed with being able to delete that incorrect record and confirm who has actually lodged that record as well.
Great. So there's just a few more requirements for deleting then. Excellent.
Yes,
Thank you.
Correct. Yep.
Yeah. And the second question, GP often gets asked to supply immunisation history for aged care residents who are unable to access their record to the facility. Are they allowed to share this, or is it a contravention of the resident's privacy?
Yeah, it could be a breach of privacy under the privacy. But can I take that question on record, and I will research some more information about that just regarding the privacy.
Yeah, sure. And I guess I think as long as you've got the aged care residents okay to share it, then it is okay, but you just have to get that approval prior.
Yes, if they have the capacity to do so, of course.
Yeah, excellent. Yeah. Great. Well, that's all the questions. So thank you, Joanne, for hopping. Oh, sorry, there is one more. Sorry, I'm just reading it.
Fine.
Can a child's overseas immunisation be uploaded to AIR and then get an immunisation history statement for the purpose of being able to send their child to daycare school if they have no Medicare card? Yeah.
Vaccination, that's a good question. So yes, of course, an overseas vaccination can be recorded. If they're not eligible for Medicare, you would still lodge that encounter. Now, there is some lovely resource material regarding that. There's an infographics on our website, on the Health Professionals Education website, which I mentioned before. And there is also an e-learning module on there. So if you'd like to go to that, it should be pretty straightforward and should advise you accordingly.
Great. Yeah. So I guess the take-home message is you don't have to have a Medicare card to have a record with the AIR.
Yes. Yes. So whenever you lodge an encounter, you're always searching for that individual. You always conduct your search with your criteria, and you can still lodge it. You would just start. You would just enter the encounter on the left-hand side of the AIR site. With your software, every software is different, so I couldn't really comment on the software, what APIs it has available for it.
Yeah. What happens when uploading vaccination records to the AIR if batch numbers are not available or provided by the patient for an overseas record? They can still be entered?
They can be, yeah. So just bear with me. I just wrote a note on that. I believe you put in there not recorded. Just bear with me a second. Check my notes on that question. I thought that one might be asked.
Yeah, Jo, that's right, Lauren. It's not recorded, all one word.
No spaces, correct, Lauren. Yep, not recorded, no spaces.
So instead of a batch number, you just write not recorded, all one word.
Yep. Correct, no spaces. Yep.
Great. If you have a patient for catch-up, but you need to individualise the antigens in a vaccine to match sequence or dose number, how do you go about this?
I'm going to take that one on notice, that question, unless Lauren's there and can answer it, because I would have to seek further information about the catch-up. Yep.
Yeah, I can just add something. It's Lauren here. I can just add something to that. So obviously, if you're looking at their history, and working out what numbers they've had before if they have got a history on air. Otherwise, it's sequential, and we can get to you some further advice once Joe checks that. So you would obviously dose 1 if it's dose 1, if they don't have any other record. But if they have had a record, an encounter recorded on the air as dose 1, then you would start at dose 2. So you just need to have a look at the individual's record for that.
I will add to that also, our system is pretty smart in the way it can determine if the dose number, I believe, like I said, not my area of expertise, but I think our system will automatically take it to that next dose number if you've incorrectly entered it. But let me get back to you on that. Let me get some information to clarify. Thank you.
Great. And last but not least, does the child need an IHI number?
Does a child need an IHI number?
I guess if they don't have a Medicare number, do they? Yeah, if they don't have a Medicare number, do they need an IHI?
An IHI number, and I won't go into too much detail about this because, once again, it's not really an Air Video's area of expertise, but I have had a little bit of training in it. But an IHI, everyone has an IHI number. With the children who are not eligible on a Medicare card, I think it creates what we call a SIN record. Once again, I'll get clarity from that specialised team about that.
Great. Excellent. Well, I'm sorry to everybody that we've gone over a little bit, but it's all been really informative. And I thank all our presenters this evening for joining us, and Mimi and Lauren for helping answer some questions. We will provide an email tomorrow with the presentation slides and also some follow-up to questions that we've had to take on notice, as well as a form for the extra learnings you can do for the RACGP accreditation points. So thank you all for joining us this evening. Please fill out the evaluation form that will pop up afterwards. And I thank you for joining us tonight.